Thank you, Dr. Ruiz. That was a great talk, nuts and bolts of hormone therapy. Our next speaker, I'm really excited. It's our first time for him with CAMAS at one of our events, Dr. Derek De Silva. He's a practicing internist with over 35 years of clinical experience, specialties in internal medicine, anti-aging medicine. He's associate staff, Department of Medicine at Ray Medical Center. And he's teaching faculty at JFK Medical Center in New Jersey. He's a past chairman of the AMMG Planning Committee, Age Management Medicine Group, and he's a recipient of the Alan Mintz Award of Excellence in Clinical Age Management Medicine. He's also the best doctor. He won the Best Doctor Award in New Jersey and New York for the past 20 consecutive years. And he's a formulator of over 350 dietary supplements, and he's a published author. He's going to be talking today about complications and how to manage them, complications of hormone replacement therapy. Dr. Derek De Silva.
Well, good afternoon. Thank you very much for the invitation, Dr. Martinez, to be here. Dr. Ruiz, that was a great review. Thank you very much. Now I don't have to do my first 10 slides. So I really appreciate that. Thank you very much. It's a pleasure to be here. I love coming to Puerto Rico. I've been to Puerto Rico, I would say, probably about 20 times. I trained a lot of doctors here on bioidentical hormone replacement therapy, and it's something that I absolutely love to do. I've been doing bioidentical hormones for about 25 years. I've been in practice for clinical practice as an internist for 36 years, and my real passion is making people better. Because so many people are in so much trouble today that they just don't know where to turn. I have to give you an example. I went to visit somebody that uses my supplements. And as I got there, he said, "I'd like to introduce you to my nurse practitioner." I said, "Great." We started talking, and he said, "Oh, I'm doing bioidentical hormones." I said, "Wonderful. That's absolutely wonderful." And he said that I'm using injections, testosterone. And then I said, "Oh, well, what else are you doing besides the injections?" He said, "Well, I also put my injection patients, my testosterone injection patients, on 1 milligram of anastrozole every day." I said, "Every day? You mean once a week? Or once every 10 to 14 days? He said, No. We use it every day." I said, "You will drive that estradiol down so low that it's going to be incredible." How many of you in here do bioidentical hormones? Hands, manos, por favor. Entonces no hay mucha gente que está usando bioidentical hormones. Well, good. You know why? Because if you're going to do bioidentical hormones, you better know what you're doing. Because you can really, really hurt somebody if you don't do this right. Men están fácil, right? You give them some testosterone, they go home and they're happy. Están muy feliz. Women, you've got to manage estrogen, you got to manage progesterone, you got to manage testosterone, you got to manage adrenals, and don't forget the thyroid. You have got to manage everything. If you want to get started with something, start with the men. Start with the men. But learn everything you can about men. Porque hombres está muy complicado, right? You think women are complicated? Men are even more complicated. So, what I'm going to do is I am going to talk with you today about managing and learning how not to get into trouble when you use hormones. I'm going to give you some very simple things to do. I'm not going to read all of this to you. You can read this. But the bottom line on these first couple of slides are that there are studies that show that if you use bioidentical hormones versus synthetic hormones, your outcomes are better. And if I'm talking too fast or anything like that, and if somebody doesn't understand what I'm saying, please stop me, because I can explain it in Spanish. Not perfectly, but I can do it. I think I can do a good job. But the bottom line here is, if you look at this was a study that came out of the International Journal of Pharmaceutical Compound in 2019. If you use bioidentical hormones, there are fewer side effects. And if you use bioidentical hormones, and this slide shows you that if you use synthetic hormones, that women just don't do well. They don't feel well. Their complication rates are much higher. So after starting BHRT, after starting bioidentical hormones, by the end of the study, they had fewer side effects. Much, much fewer side effects. Folks, the body knows what to do with something that it recognizes. If I give you a plant, your body knows what to do with that plant because the body knows it. It understands it. We eat plants. Our body knows how to digest them, how to utilize them. Our body doesn't know how to use plastics. Our body doesn't know how to use xenoestrogens. Why? Because the body doesn't recognize it. So what does the body do with that? The body does other things, uses other mechanisms, and as a result, this is where the cancers, this is where the other bad side effects come in. You have to give the body what it needs to do what it needs to do. It is that simple. And again, another slide here. The most common side effects of weight gain, breast tenderness, and bloating were found more prevalent in conventional BHRT, in conventional hormone replacement therapy, than with bioidentical hormones. Again, you can read the slides. I'm not going to read these to you. And that's what this is showing. Again, the data is very, very compelling. Synthetic hormones. My mother, God rest her soul, she passed away about 18 months ago. She was on estrogen. She was on Premarin for 30 plus years and ended up with breast cancer. We know that. We know the data. We also know that the data from the Women's Health Initiative, the WHI study, is again very compelling. They used the wrong estrogen. They used synthetic estrogen. And what happened? All of these women developed breast cancer. They stopped the study early. But how many of you know that the lead author of that study from Johns Hopkins, also repeated the data, reanalyzed the data, and I think it was probably about 7 years ago, said that we used the wrong estrogen. And we didn't give those women progesterone. How many of you know that study? A handful of you. Less than a handful of you. This is the problem, folks, is that we don't hear the data. We hear what pharma wants us to hear. So you need to pay attention. You need to attend conferences like this and make sure that you're up on this. So what are some of the basic tests? And Dr. Ruiz was going to go over this, but I will. You need to do a full comprehensive metabolic panel, and I'm going to tell you this. You first have to be a good doctor. Because if you don't know how to manage the thyroid,
and you're an OBGYN and you've never managed the thyroid, make sure that you work with somebody that knows how to manage the thyroid, whether it be internal medicine or endocrinology or somebody. But we have to be talking the same language. If you're going to work with an endocrinologist who has no idea what Armour thyroid is or NP thyroid is, don't work with them, because they're going to be sticking these people on levothyroxine, which is T4. So work with people that you know you're comfortable with, that have the same brain that you do. So these are some of the basic tests. A full CMP, lipids, hemoglobin A1C, and folks, I also do insulin levels. Why do you need to do an insulin level? ¿Por qué? ¿Por qué tú tienes que hacer esto? Los niveles de insulina. ¿Qué tú piensas? ¿Qué usted piensa? Perdón. If you do a blood sugar, it's what's your sugar right now, ¿verdad? If you do a hemoglobin A1C, what is your hemoglobin A1C for the past 4 months? But if you do insulin, and you can show this, we know that testosterone increases the sensitivity of insulin. We know that for a fact in men. The data is very clear in men. The data is not as clear in women, but we see anecdotally, preliminarily, and we tried to publish a paper on this, by the way. I was part of a group that tried to publish a paper on this, and the paper was rejected by 3 journals. I know why it was rejected. I was one of the lead authors, and I know why it was rejected. I don't want to get into the politics, but the bottom line is that if you can show decreases in insulin levels when you start to use BHRT, that is remarkable. You will never, ever, ever lose weight if your insulin levels are elevated. And what's elevated? I keep insulin levels below around 7, 8. That's where I want my insulin levels. Because if you're, I think in the lab it's up to 12 or 15. It's too high. It's like homocysteine, right? You can't have a homocysteine level of 15. Homocysteine should be 7, again, in that range. Why will you never lose weight? Why will you never lose weight if your insulin levels are elevated? ¿Por qué? Don't be afraid, just yell it out.
You're compensating.
I'm sorry?
You're compensating.
Well, insulin is a lipogenic substance. Insulin builds fat. So every time I give you insulin, or every time you increase your insulin when you eat, you're going to build fat. Now, when I give you hormones, when I give you bioidentical hormones, what's going to happen is that I can show you over a period of time that your insulin levels are going to start coming down and you're going to start losing weight. That's the key. So that's why I do insulin levels. I do a thyroid, T4, TSH, and I underline free T3. Free T3 is the active form of the thyroid. I do a vitamin D level. I do a vitamin B12 level. By the way, if you're going to start metformin, what test do you need to do before you start metformin, and why? You need to do a vitamin B12 level because metformin depletes, it completely rips B12 out of the body. So before you start metformin, make sure you have a baseline B12 level. And I'm telling you right now, the B12 level is going to be 300, maybe 400. And then you're going to give them metformin, and the B12 level is going to drop to 100 or 200 every time. That was reported in the journal of the British Medical Journal many years ago. Testosterone free in total, estrogen, progesterone levels, FSH levels, DHEA levels, obviously a PSA in men, and a DHT level in men and in women. Why do I need a DHT level in women? Because they have prostates? No, we know women don't have prostates. I'm going to tell you in a little while. But you do need to have a DHT level in women also. Baseline, I will not start women on hormones unless I have a mammogram, I have a transvaginal ultrasound, not always have to have a PAP. Why do I need a transvaginal ultrasound? For what? Exactly. What is the endometrial lining like? Because if you start them on BHRT and they start to bleed, you have no baseline. You have nothing to compare it to. So do the transvaginal ultrasound. And also, make sure your patient fills out a symptom form. How do you feel? What's your libido like? What's your skin like? What's your sleep like? Because you know what? After 3 months, they forget. And they say, well, this isn't working. I don't feel any different. You have the form. Have them fill that form out again. People forget. So what is our goal? We want to maximize quality of life. We want to minimize complications. And we want to minimize the side effects of the therapy. And folks, this to me is critical. How do you judge the success of any therapy? The success of any therapy, whether it be thyroid, whether it be hormones, any therapy, is based on what? How do you feel? Don't, and I'm telling you right now, don't treat numbers. Treat the patient. If you treat numbers, it's just, for me, it's wrong. You have to treat the patient. The numbers are there for a guideline. They're guidelines. Some women feel really good with a testosterone level of 50. Some women feel terrible with a testosterone level of 50. They need to be at 70 or 80 or 90. And here's the other thing, is keep things physiologic. Try to keep things physiologic. Now, I have one lady who just loves to have a testosterone that's very high, but she's an exception to the rule. And I made a note in my chart that says, this is what she wants, and this is what she needs. Now, these next couple of slides, I don't want to go over because Dr. Ruiz did a great job. And folks, I'm telling you right now, what he did, and I don't know that if you realize the significance of estrione, estriol, and estradiol, you need to understand all three of those forms of estrogen and what they do. Using the biased and doing all of these things together. Again, you can read through this, but he went through most of this. If there's anything that stands out, I'll bring it back to you. Yes, and I'm really glad that he mentioned the alpha and the beta receptors on estrogen. And also the GRP receptors. What other botanical hits the GRP receptors? There's another plant that hits the GRP receptors that are getting very common today. Cannabis. Cannabis is another thing that hits the GRP receptors, which is remarkable. The role in preventing coronary artery disease for estrogen, obesity, and again, insulin resistance. Why? Because estrogen and testosterone increases the sensitivity of insulin. the GI effects of estrogen, positive effects with regard to the gastrointestinal system, the brain, absolutely, the roles in cognition, roles in preventing Alzheimer's. Again, this is something I just mentioned, insulin sensitivity, insulin resistance. Some of the symptoms, and by the way, there are some crossovers, right, between estrogen, progesterone, and testosterone. Here's what I do. A lot of times, the way I base my estrogen treatment for women is, one question is, what about vaginal lubrication? Are you still having pain during intimacy? That is my gauge for how is your estrogen level. Because I want to keep women's estrogen levels, again, physiologic. But if she says to me, todavía se me molesta, or todavía se me duele, I am going to take her up on her estrogen just a little bit. So there are some crossovers. Now, Dr. Ruiz also mentioned this, and I want to show this to you because this is important. We want estrogen going down the 2-hydroxy pathway, and he pointed this out beautifully. We don't want estrogen going down the 4-hydroxy pathway. We don't want it going here. How many of you know what DIM is? Diindolylmethane. One person, 2 people, 3, well, of course we know you know what it is. Folks, I, in 25 years, have never used anastrozole in any of my male patients, ever. Ever. Because there are other things that are a lot safer to do during your practice. And I'll come back to that in just a little bit. But how many of you use DIM for women? 1 person, 2 people. Every single one of you that are doing hormones needs to be using DIM in women and men. Why? Why do you need to use DIM? By the way, DIM is diindolylmethane. It is an extract from cruciferous vegetables. What DIM does is that DIM pushes estrogen down the 2-hydroxy pathway. So what DIM does is that it pushes estrogen right here. DIM is protective for the breast tissue, for the uterus, for the ovaries, and for the cervix in women. So when you use estrogen, make sure that you give them DIM. Now, people say, well, what about indole 3-carbinol? Indole 3-carbinol is another nutrient. For me, it's like giving people vitamin D2 instead of vitamin D3. Why do you want to make the body work more? Because it's got to convert D2 to D3. Why are you doing that? Give the body what it needs. Give the body DIM so it doesn't have to do that extra work. Okay? Does everybody understand that? And that's important. Progesterone. How do I judge progesterone? The way I judge progesterone is I look at women and I say, Amor, how are you sleeping? How's your sleep? And another thing I add, and by the way, if a woman starts to gain weight, you will be the first person to know. Right? If she says, and if a woman calls me and says, I'm starting to feel squishy. Why is she feeling squishy? I like that word. Because that's what my female patients say. I feel squishy. What is that? That is the estrogen, because estrogen loves to hold on to water, and estrogen loves fat. So women will say, I start to feel squishy. You're giving them too much estrogen. With regard to progesterone, how are you sleeping? For me, again, that's how I judge that. So progesterone, again, and again, to reinforce what Dr. Ruiz said, I don't care that you don't have a uterus. I don't care that you don't have a uterus, because progesterone has other protective effects. It is not just the uterus. It's the brain, it's the heart, it's sleep, it's all of the above. Again, Dr. Ruiz mentioned this, so I'm not going to go into that. Again, there's a lot of crossover. There's a lot of crossover between estrogen, progesterone, and testosterone. They all just don't do one thing. They all don't do this. There's a crossover between all of them. Again, I'll use his words again, it's balance. It's all about homeostasis. It's all about balance. And again, testosterone is not just for men. We would have some very, very, very boring women if you didn't have testosterone. So, any woman that's in my life, she's got to take testosterone. Otherwise, olvídate. No estoy interesado. But seriously, it isn't just physical. It's mental, it's emotional, it's cardiac, it's insulin. It's all of the above. And I'm keeping an eye on the time so that I don't go over, because I know you're probably getting hungry, ahora. So testosterone, again, just some data very quickly. Men ages 30 to 70 lose about 1 to 3% per year. Women ages 20 to 40 lose about 50%. That is mucho. That is a lot. And by the way, we need to keep an eye, remember as I told you, you need to have DHT levels in women, and you need to have SHBG levels in women. Because you have to know if something comes up, what is going on. And you have to have a baseline. Again, Alzheimer's disease, women have 8 times higher risk of Alzheimer's disease over men. Again, the whole idea of beta amyloid, decreasing beta amyloid. So what are the complications of BHRT? We've got bleeding. We've got hair loss, hair growth, high blood pressure, weight gain, bloating, and loss of libido. How can you have loss of libido if I'm giving you hormones? Let's start with the one thing that I do know, that if a woman loses hair, or if she starts to grow hair in places that she doesn't want to grow hair, or if she gains weight and it starts to bloat, you're in trouble. Because they will wait for you in the parking lot, sentado al lado de su carro. True? If a woman gains weight, you're done. They will kill you. So what you need to do is you need to make sure that your dosing is right. One of the biggest things that I see are a lot of people are using dosing sites. I don't have a problem with that. I really don't have a problem with dosing sites at all. The problem with dosing sites are, what's their end goal? Do they want testosterones at 200 or 300? Or do they want testosterones physiologic, whatever that number is for you? Where do you want your estradiol level? Where do you want your progesterone level? What ratios are you looking at? So, dosing sites are good, but you need to know what the end result is that you're looking for. A lot of times what I see is when we try to dose, when we're dosing estrogen, for example, and I keep saying estrogen, estradiol, they'll say, and I'm talking about pellets here, 12.5 milligrams. I never start with 12.5. I always start a little bit lower. Because that 12.5 for the first time, women are going to go, and they're going to bloat, they're going to get squishy, their bellies are going to get bigger, and you're not going to feel good. Start lower. And then perhaps, remember, you don't want to keep dosing estrogen every single time. If you're giving a woman pellets, you want to do it every other time. And here's the other thing. If you are doing pellets, or if you're, whatever, hormones in general, folks, initially, I like to see what the levels are at about 6 weeks. Okay. But I don't do it every time I do pellets. Why? What I need to know is 3 months later, 3.5 months later, or 4 months later, when I'm getting ready to pellet you again, what are your levels? What are your levels? If your testosterone is 100 still, and your FSH is 20, and your estrogen is 50, do I need to even pellet you? Do I? Yes or no? What's the question? How do you feel? Again, the numbers are just guidelines. How do you feel? That's what we've got to come to. Also, medicine is an art and a science, right? It's not just esto, y esto. It's what part of that do you need to do? So if a woman starts bleeding, bump up the progesterone. And by the way, I don't like progesterone pellets. I'm just telling you how I feel. I've been doing this a long time. But I think progesterone pellets are crazy because you can't really adjust if somebody starts bleeding. You know, if you start bleeding and you're on 100 milligrams of progesterone, I can bump you to 200 and see what happens. But here's the other key. You have got to find a Dr. Ruiz because I'm an internist. I know the basics, but he's got to help me. And you've got to find, and I have the word friendly, OB-GYN, that you can work with that knows BHRT. So this is also where the transvaginal ultrasound comes into play. What was the endometrial stripe? How thick was the endometrium? And now if you need to do another transvaginal ultrasound, you have a baseline. Hair loss. Hair loss. I have women that have beautiful, beautiful hair. They start losing their hair, you're done. You're done. The biggest mistake with hair loss is what? Too much testosterone. Folks, start low and go slow. I don't need you to become Superwoman on the first insertion. And you have to manage women's and men's expectations. This is not going to make you 18 again. It's not going to happen. You have to manage their expectations. Here's the other thing I do. I give every woman saw palmetto when I pellet them. Because if they start to convert or block and convert some of the testosterone to DHT, what are they going to do? They're going to lose hair. So as a prevention, I give them our prostate formula, which is 3 times a week. Not every day. Not every day. It's 3 times a week. What does saw palmetto and Pygeum africanum do? It blocks the production of DHT. So 3 times a week. If you need to go higher, you can go higher. it doesn't matter that women don't have a prostate. Because also, saw palmetto-pygium africanum is used in women that have pelvic inflammatory disorders because it reduces inflammation. The other thing you have to look at is what's the pattern of balding, or what is the pattern of hair loss? If the pattern of hair loss is a male pattern balding in the crown area, you know that it's probably DHT, right? Whereas if it's diffuse hair loss and it's loss of eyebrows and eyelashes, then what's the problem? Thyroid. This is where you need to have the baseline for thyroid with a free T3 also. DIM also sends estrogen down the 2-hydroxy pathway, but it also unbinds. If your SHBG levels are high, if your serum hormone binding globulin levels are high, DIM unbinds the testosterone and sends it into the free testosterone realm. Another reason to use DIM. Excessive hair growth? Yes, women will come after you for this also. Not enough hair, too much hair. I don't use spironolactone. I don't. I've never used it. I never have used it. Again, start low and go slow. Keep the testosterone at physiologic levels, not super physiologic levels. What happens if somebody increases their blood pressure? And this happens more commonly in men, by the way, because we give them higher doses of testosterone. What do you do? What do you do? Why do they raise their blood pressure? Because they start to hold on to water. So give them a diuretic every other day for a week or so, and that'll come right back down. Let the body normalize. Let the body do what it needs to do. And physiology will take over. Because what's happening is between the testosterone and between the estrogen, the body just starts to hold on to water. So something like diazide, hydrochlorothiazide, every other day for a week, 10 days, and they're fine. That doesn't need to be continued indefinitely. And the next time you put some testosterone in, just decrease the dose. Weight gain, too much estrogen. You started with way too much estrogen. Again, this is another reason that you can use a little bit of a diuretic. Again, be careful. You have to know blood pressure. So if a woman says to me, I'm starting to gain weight, and I can't change the estrogen dose, I'll have them come in, I'll check their blood pressure, and then I'll give them a small dose. I personally, and I want to talk to Dr. Ruiz about this, I personally really like sublinguals also. Now, I don't know how you feel about that, but I need to have that conversation with you. But I like sublinguals, I really like pellets. The problem is you can't manage those pellets. This is why I'm telling you to start low. Don't start at very high doses with any of these things. Because again, the weight gain will also stabilize out, especially when you put in that first dose. Okay? So you want to start a little bit lower, and on the second insertion or the second round, you can go up a little bit more. Be conservative. Be conservative. Loss of libido. I don't want you to read that. Why can you lose your libido? You're getting testosterone. How do you lose your libido? What happens? Sorry? Adrenals have to do with it, absolutely. What else? How can you lose your libido when I'm giving you testosterone? If I give you too much, what's going to happen is you're going to supersaturate the receptors. Once you supersaturate the receptors, there's a J curve, and all of a sudden, your levels start to drop. and you get up to levels that are 1,500, 1,600, 1,700. For me, physiologically, I am really good at around 900 to 1,000 of testosterone. I have gone up to 12, 1,300. Way too much for me. Way too much for me. And what happened was, yes, my libido actually did come down because I supersaturated those receptors. And you will start to see, as that number starts to come down from 12, 1,300 back to the 900, you start to feel good again. So again, I don't know how much you need. My dosing calculator is going to tell me one thing, but how do you feel? That's where it comes in, and that's where it's really, really important. What about anastrozole? And this is just a slide to tell you that. What about DIM in men? Why do I need to put every single man on DIM? And by the way, does every single man need to go on DIM? Sí o no? Tengo un minuto. Does every single man need to go on DIM? Yes or no? Do I need to take DIM every day? No. Why? Because I'm not aromatizing. I want to keep my estradiol levels between 40 and 60. I want to be at 40. I don't want to be at 10. I don't aromatize, but I do need DIM. I take it every other day. And I check my levels. And how do I feel? Now, if I were 210 pounds, do I need to take DIM? ¿Sí o no? Sí, ¿por qué? Porque I'm going to aromatize. If I'm 5'7" or 5'8" and 210 pounds, I'm going to aromatize. So if I'm going to aromatize, I'm going to give you the DIM because your baseline is going to be 60, right? I'm going to now give you testosterone, and you're now going to go from 60 to 110. So, again, know what you're treating and know what you're doing, and don't use the drugs. You don't need to. You don't need to. Because I can give you DIM, prevent that aromatization. I can do it twice a day. I can do it 3 times a day. I can give you prostate to unbind the SHBG and keep your DHT levels down. So there's all kinds of things that I can do. What are some of the basic nutrients for women? Absolutely a probiotic. It all starts in the gut. Hormones are made in the gut. I've got to give you vitamin D with vitamin K2. Vitamin K2 activates osteocalcin and activates matrix GLA protein. So it activates and rebuilds the bone matrix, and it keeps calcium out of the intima of the vasculature. 150 milligrams of DIM once a day, saw palmetto 3 times a week, and you've got to take B vitamins. If you don't have B vitamins, you can't make estrogen. In men, probiotic, same thing. Probiotic, vitamin D, DIM twice a day, again, and I put based on the body habitus, saw palmetto daily, and methylated. 60% of you in here can't methylate. I don't know who you are. And as Dr. Ruiz pointed out, you have to be able to make sure you methylate. If you've got a COMT break in your methylation pathway, you're going to be in trouble. You're going to be more predisposed to neuropsychiatric problems. So a methylated B12, a methylated folate becomes extremely, extremely important. Start low and go slow. Encourage good diet and lifestyle. Support the patients with some basic supplements. Partner with a friendly GYN, and partner with a urologist for the men. This is all my contact information for those of you that need it. Don't text me at 2 o'clock in the morning. I will send you a nasty message back. If you want to talk to me, do it during business hours. And as you can see here, there's all kinds of information. I'm happy to share all of that with you. And this is always my last slide. I was trained by the Franciscans. And folks, the bottom line is we just need to be good people who love each other, who care about each other, but most importantly, who just embrace each other and be with each other. Thank you so much. Muchas gracias para todos. Tengan un buen día. God bless.
Thank you, Dr. Derek. We need to move to lunch, but any questions? We can allocate a few minutes. Questions on the back.
But what do you do with a patient that are allergic with aspirin that they can not use soft palmetto?
A patient that's allergic to
Allergic to aspirin.
aspirin
Yeah.
that can,
They can be allergic to soft or palmetto.
oh, to saw palmetto. There is a very, very small crossover. Small crossover. If that is an issue, don't use it. Don't use it. Use the DIM because there's no issue with the DIM. But there's a very, very small percentage of people where there's a crossover. That's a great question. Mira, voy a estar allá
Another.
Ok, solamente una más, ¿ok? Porque tengo hambre también.
Una nada más. About PSA on men.
Ajá. Dime en español, dime en español.
No todos los pacientes, pero a algunos les mando directamente el MRI porque yo sinceramente pienso que el PSA es tan malo muchas veces. Si tienen historial familiar de cáncer de próstata y si tienen próstata agrandada, a todo el mundo le mando el MRI. Y he tenido 2 pacientes que han estado años con sus médicos, nadie le ha mandado el MRI y ya identifiqué 2 con cáncer.
Ok, déjame decirse, contesta eso 2 veces. Primero, cáncer de próstata es en qué edad en hombres. ¿Qué edad? 50, 60, 70, ¿verdad? Bien. ¿Qué son los niveles de testosterona en una persona, en un hombre que tiene 18 o 20 años? ¿Qué son los niveles? 1500, 1600, 1700. Folks, testosterone does not cause prostate cancer. If testosterone caused prostate cancer, every 18-year-old would have prostate cancer. Dr. Abraham Morgenthaler, who I know very well, treats men with prostate cancer con testosterone. And guess what? They're doing better. Ahora, if you've got a family history of prostate cancer, okay, and the PSA is greater than 2.5, yes. Do I send them to a urologist? Yes. Get an evaluation. If you want to do an MRI, I think that's a great idea. That's why I do the transvaginal ultrasound in women, right? Just to check that. But just so that you know, testosterone doesn't cause prostate cancer. It doesn't.
Aquí en Puerto Rico le he encontrado un solo urólogo que sepa sobre el tratamiento bipolar androgénico que está le testosterona a los pacientes de cáncer.
I'm telling you, I spoke at Dr. Morgenthaler's conference 3 years ago in New Orleans. Out of the audience of 250 urologists, they Johns Hopkins, they Harvard, NYU. Do you know what? Dos médicos sabía que estaba DIM. 2. Uno fue un chiropractor y el otro fue un naturopath. Los otros no sabían nada sobre DIM. This is the problem. Gracias. Tengo buen día.